Welcome to the Point of Medicine podcast, brought to you by LearnNeuralTherapy.com. Doctors Hill and Ilana Gurevich team up to take a deep dive into the art and science of healing. This podcast explores cutting-edge approaches to the autonomic nervous system and its role in organizing fascia for optimal health. Each episode features conversations with leading clinicians who are pushing the boundaries of medicine, uncovering new insights, and transforming patient care. Join us as we bridge tradition and innovation to expand what's possible in modern healing. Just a reminder, this podcast is for educational and entertainment purposes only and not intended as medical advice. Please consult your healthcare provider before making any changes to your healthcare plan. Join us and let's jump into the next episode. Hello, and welcome back to the Point of Medicine podcast. We are exceptionally fortunate today to be joined by Dr. David Vinyes, who is maybe the clearest, one of the most experienced neural therapy teachers that I think any of us had gotten to work with. And I have watched David teach a multitude of times, and each time we leave with a deepening, stronger understanding of the foundation of this medicine. And so we're so eager and excited to talk to Dr. Vinyes about neural therapy and his practice. Dr. Vinyes, will you give us a little history about how you came to neural therapy?
How I keep neural therapy?
How you came? How did you start learning neural therapy?
Okay. Thank you for inviting me for this opportunity to talk with you about neurotherapy. We have this common point in our life that it's neurotherapy, but also a way in doing medicine, because in fact it's more than a therapy. It's a way of doing medicine with our patients in our approach to the patients who had some problems, and most of them has not resolved with other therapies or the kind of approaching medicine. So I started neurotherapy just when I finished my career. I'm a medical doctor, and just when I finished it, I discovered neurotherapy, and I met a doctor from Colombia who was Julio César Payán de la Roche. He was the dean. He was the dean of medical faculty in El Cauca. He also was the national award of medicine. So he was a very recognized doctor. But when he started with neurotherapy, he had to leave everything, all this conventional medicine, official medicine, because he was not allowed to do neurotherapy in the hospital or in the faculty of medicine. So he chose to do neurotherapy in order to continue being the dean or the chief of the gynecology department of the hospital. So I was very lucky, and I'm very lucky because I could study and learn neurotherapy with Julio César Payán. And I was in Colombia. I started with him in 1993, and I decided to stay with him in Colombia in 1996. So since then, I've been doing only neurotherapy. So I've been treating every kind of patient, every kind of disease, only with neurotherapy. It's my unique approach. And on those days, the only way to learn neurotherapy were small courses. There were very few courses in this world, or to be in the office with your teacher. And that's the reason because I started to do some courses in Barcelona, because some people asked me to teach them neurotherapy. So I realized that I had not only to visit patients, to attend patients, but also to teach neurotherapy to these colleagues. So I started in 2000 to teach neurotherapy. So for 25 years, I'm teaching neurotherapy. And for 20 years, I have taught neurotherapy, and still I'm teaching in the University of Barcelona. So we had a master's degree in the University of Barcelona. This university is the main university in Spain, who has the highest level in Spain, always in the first 100 universities in the world. So we are doing our master's degree there. And we're doing also other kind of, I'm doing also other courses in different countries. As you know, I travel and I teach neurotherapy in different countries in Europe and America. And I think that, as you know also, because we are teachers, that when you teach neurotherapy, it's one of the best ways to learn neurotherapy, because a lot of people ask you some questions that perhaps you haven't never asked that. So you have to think about that, or you have to try that. And also you receive also a lot of feedback from the other doctors, the other therapists. So with this feedback, you learn a lot. So this is my way of starting in neurotherapy, and also I was the founder of the Spanish Neurotherapy Society. And also I'm collaborating with other societies. That's a reason, because I am the honorary member of other societies, like, for example, Italian or Colombian, Ecuadorian or Turkish also, and Austrian societies. So I'm really in the middle of a network of neurotherapy societies, and I'm very happy about that, because I think it's worth it to connect, and I like very much to connect these different societies, and also to connect South America with Europe and also with North America, because there are different approaches of neurotherapy, and if we connect all of them, I think is also is very, very good for all of us, because we can learn from each other.
Can you also speak? One of the most powerful things that I think you're doing is actually conducting research and publishing data on neurotherapy, which, at least in North America, if you want a treatment to gain traction, you have to be publishing about it. And I think you publish about it more than anybody else. Can you just explain to us what you're doing as far as publishing data on the efficacy of neurotherapy?
Well, most of the papers in neurotherapy are in German, and they are all papers, but most of them are not studies. We published a scoping review in a good journal. It was Journal of Clinical Medicine, and we published this scoping review about the basis, the scientific basis of and the mechanisms of action of neurotherapy, and realized that most of the papers in German, there are a lot of them, they are not, you cannot find them in database, because, or you cannot include them in this review, because most of them are articles about opinion, about experiences, but they are not studies. And nowadays, the country who has more papers and more research in neurotherapy is Turkey. It's Turkey, with Hüseyin Naslikul, Dr. Hüseyin Naslikul. Nowadays, they are conducting 22 doctoral thesis, for example, and they are doing a lot of research there. So it's the main country in research in neurotherapy now. But a few years ago, Switzerland and Germany also were some countries that have published also some papers about neurotherapy, and also Colombia, of course. And for the last years, we have published 5 papers about neurotherapy, but most of them are not really impact studies, because they are only case reports, because we realize that if we want to do research in neurotherapy, you can choose a very high level of scientific research, that it means clinical trial, for example, or high level of neurotherapy approach. So it's different. If you want, as we know that neurotherapy approach is very individualized, it's very difficult to do a clinical trial. So if you want to do a clinical trial, double blind clinical trial and randomized, you will have a very high level of scientific consideration. But it's not possible to do that in neurotherapy. Like surgery, for example, because you cannot do a double blind clinical trial with a surgery, with acupuncture. So, in fact, most of the studies must be pre-post treatment and control and group and control studies also. But in my mind, I have also the goal, the aim of doing a clinical trial. But of course, I know, and we have to. If you say that this clinical trial is not really neurotherapy, but it's useful for neurotherapy, I think it's okay. You only have to be clear what are you studying, and you can do everything if you explain that. But it's very difficult, because, of course, in States, also in other countries, if you want to apply neurotherapy in a hospital or in a public service, or you will be required for a scientific basis, for scientific evidence. So we have a lot of experimental evidence. We have 1 century. You know that this year there is 1 century of neurotherapy. This year we have 1 century of neurotherapy, 100 years doing neurotherapy, but experience is not enough. They will ask you scientific evidence. So that's the reason, because it's very important. Even if you don't like that, even if you are not good in that, it's very important that we have some studies about what we are doing, not only experience, not only articles, opinion articles, also studies. Because if not, it will be very difficult even to continue doing neurotherapy, because sometimes we have some problems from the health services, because they are always asking for this evidence. So words are not enough. We need also studies. And if we don't like that, doesn't matter. We have to do that. And that's the reason because I also decided to do research, and I have published some papers for the last years. But the most important studies, I hope, I will conduct in next years.
Great. That's wonderful. I'm just curious, you mentioned Turkey. Are they doing some of these like larger kind of controlled double-blind studies, or what's coming out of Turkey?
Well, I don't know exactly. I know the studies they have published, but I don't know exactly what the goals and the questions they are doing in this doctoral thesis. But as I have read all the papers they have published already in neurotherapy from Turkey, it happens sometimes that the the paper or the approach of neurotherapy is linear. It's not my way. For example, there's a paper talking about epicondylitis, or there's a paper talking about migraine, for example, or a paper talking about low back pain. So sometimes we apply neurotherapy like a pain treatment, It's confusing because people can confuse procaine injection or local anesthetic injections for pain, and it's like anesthesiology. It's like pain therapy, and this is not neurotherapy. So it's very important that when we publish a paper about neurotherapy, not to do this kind of articles, because I think they are confusing. So I prefer to, for example, to write papers about other diseases, other complaints, not pain, because there are a lot of papers about pain and sometimes confused. So about anxiety, for example, or about mental disorders or endocrine disorders or infectious disorders, or people with a lot of comorbidity of dysautonomia or post-COVID, but not about pain. And if we want to do a study about pain, we have to explain that we are not injecting the painful point. And in this case, if we do, for example, a clinical trial, in some patients we inject the point of epicondylitis with procaine, and other patients in the control group, we inject the same point, for example, with saline solution. This is not neurotherapy. This is a local anesthetic injection for pain. So we must be very clear, because sometimes you know that after teaching a 2 year course, a lot of weekends teaching neurotherapy, sometimes the student still think that neurotherapy is injecting the painful points, the tender points, with local anesthetic. So after explaining that several times during the course, because for us it's very difficult to change our mind, and we are prepared to think that we have to treat the symptom, to treat the pain, and we have a local anesthetic, and we think that this is a treatment for the pain. No. You have to see the whole person, and if the person comes with pain, okay, so you have to leave the pain just besides the patient, and to do the history of life of the patient, and to see if there are any interference fields, and if there are other symptoms, if you can connect other symptoms, and most of the symptoms are not related with pain. If you can connect that, and you treat the patient, not the pain, the patient. And if the treatment is good for the patient, and the autonomic nervous system is more balanced, and the patient is better and feels better, the pain will improve or even disappear, but not as a consequence of the treatment.
So you're basically trying to publish data that changes the way that people think about disease, which is even more difficult than publishing papers on just neural therapy.
Yeah.
Yes, this is the main point. Because in fact, in neurotherapy, the main point when you start a course is to understand that we are not treating the symptoms. We're not treating the pain. We're not treating the disease. We are treating the patient, because everybody says that. Everybody says we treat people with not diseases, but in fact, If you go to the hospital, if you go to any office, any medical office, you will see that people are treating diseases, treating symptoms. So this is the main point. If people don't understand that in a course, they will not understand neurotherapy. They will inject local anesthetic, but not understand neurotherapy. So, and it's very important in research also to be very clear with that, because it's very dangerous. Because in research, as we want to use a scientific model, is very difficult to use a qualitative and individual treatment and a qualitative and individual research. But we have to be very conscious and to try to do in the best way this point of view.
I think it's interesting to me because I do think I understand what you're saying, but I do think getting more physicians interested in neural therapy, I think is going to be about starting at where they're at, which is treating the symptoms, and then pulling them in and being able to help change their mind to understand, through what we do about how to treat the patient. So, anyway, that's just my 2 cents, but I think that's great that you're doing that. I heard through the grapevine, Dr. Vinyes, that you're maybe working on a new updated textbook. Is that correct?
Yes. I've been working with this textbook about neurotherapy for 2 years, working 50 hours per week, more or less. So a lot, including weekends, including my holidays, because there's a very, very huge work. But I'm very happy because we are finishing it now. I'm working with some the dubs of the publishing editor, the dubs, and also with the last dubs and corrections of the figures, and also about I'm working with the videos, because this book will have text, figures, and a lot of pictures, and also videos with a QR code. So I hope we will have this video in Spanish this May, so in few months. And after that, I will work to translate this book into English. I hope we can find a medical publisher to publish this book in English, because in Spanish it will be published through the largest medical publisher in Spanish. You can find these books of Panamericana Editorial in all countries, from Mexico to Chile and Spain. In all Spanish-spoken countries, you will find this book. So I would like to find out a publisher in English also in this level, in order to be possible to find this book, a book in neurotherapy, in everywhere. But also because if we publish in a medical publisher, it will be easier to introduce neurotherapy in hospitals or in faculties, because you know that if you publish a book with a recognized publisher, its doors will open easily. And also in this book, we talk only about neurotherapy. We don't talk about chakras. We don't talk about meridians. We don't talk about anything else, because you know that a lot of people will think if you talk about that this is holistic medicine and integrative medicine, they will do a prejudice. I don't know if you say prejudice? Yes. Because they think something, they have a prejudice about Chinese medicine or about Ayurvedic medicine. So if you talk about that in this book, so all the prejudice from other point of view, other paradigms will be put on you. We talk only about neuroscience, anatomy, physiology, interference field. So we introduce a lot of concepts, of course, because we introduce about interference field, and we introduce about the enlightened phenomenon. We talk about more than 100 history of life, more than 100 cases in this book also. Because when we, for example, talk about a technique, we explain the anatomy, we show the anatomy, we explain about the material and the technique, and we show with photos and videos, but also all the techniques are accompanied with a history also, a real history of life. In order to understand that, for example, if we are talking about stellate ganglion, we have to know in what cases you have to inject there. It's not only important to know the anatomy and the technique, you have to know when a stellate ganglion is required or it's supposed to be injected. So the best way is history of life, the real history of life. Why you injected stellate ganglion in that patient, and what was the reaction, and what was the following up of this injection. Not only the technique, real cases. So this is the book, and very excited about that.
Yeah.
Excited because 2 years working a lot, but we are nearly finishing it.
So you think you'll be published by the end of 2025?
No, in May. This May.
Oh, in May.
Yeah, in 4 months. I hope before the Germany Congress, the Germany conference. Perhaps 2 or 3 weeks before.
That's incredible. What
That's
an incredible
amazing.
feat. It's like
Yeah.
you climbed a mountain.
Yes, yes, yes. We will have this book in 2 years, so we have worked a lot. Yeah.
So I was just going to say, we always kind of joke because, like, with our students when we're teaching, because the books are so old, like, you know what I mean? They're so outdated. It's going to be amazing, actually, to have
Yes,
a
and
modern book. Yeah.
there are a lot of co-authors, and we have also, Richard Nass. Yes, he's also a co-author. He's the author of the interference field chapter, and we have a lot of authors from different countries in like Germany, Switzerland, Turkey, Spain, Italy, Austria, and in Latin America also from Mexico, Colombia, Peru, Ecuador, Chile, Argentina, Brazil. So I wanted to have different authors in order to show also a common point of view, but also with some differences. So I think that neurotherapy, there's no, that neurotherapy in the beginning was called neurotherapy according to Huneke. It was because, of course, Walter and Ferdinand Huneke were the first that they were talking about neurotherapy. But of course, procaine and local anesthetic were used as a therapeutic before Huneke, but they started with the point of view or with the methodology of neurotherapy. So the treatment with local anesthetic as a methodology, not only using a local anesthetic, usually procaine in that period, because there was the only local anesthetic in the beginners of the last century. But Huneke, the brothers, were the first who started with this methodology. But of course, when I started with neurotherapy, so 30 years ago, all the courses were and all the places you can read neurotherapy according to Huneke. And I said, wow, how can I do or apply neurotherapy according to Huneke? I don't know how to do that. I only can work with neurotherapy according David Vinyes. So I'm sorry, but I cannot do neurotherapy according to Huneke. So it's supposed that nobody can do a neurotherapy according to David Vinyes or according to Ilana or Anne, or they cannot do neurotherapy according to other person. So you have to teach neurotherapy, not according a school. And when you see how people apply neurotherapy or how their techniques are different, because in some countries there are different ways of injections. Also in a congress, when you see people, or in a workshop when you see people how they inject in different ways. So, and some people inject as they were taught 20 or 30 years ago, and that they inject and they're doing the same injections, and the techniques have changed a lot. So one of the works of a friend of mine, Fernando Cordova, who passed away 3 weeks ago, or me or other authors, we wanted to update the techniques in order to be safer and easier, and also, of course, effective, the same effectiveness. But for these decades, we have changed some techniques, and now they are easier and safer. So we have to show that in order, not only for the new neurotherapies, also for the old therapies, because perhaps they have to update some techniques, and also to remember this paradigm to treat the patient, not the pain, because a lot of people who are doing neurotherapy for many years, they are still treating the pain or treating the disease or the symptoms with local anesthetic and with all techniques. So we have to change, or at least to advise of these new techniques and approach.
So, David, when Anne and I teach, one of the things we teach is pelvic injections. And both of us were trained on Frankenhausen, using a very long needle, going through the entire pelvis. And I think after I was taught to do Frankenhausen, maybe I did it once in my practice. It was very unruly. I did not feel comfortable injecting at all, and continued to use the Frankenhausen every week. And then when I was fortunate enough to listen to you lecture in New York, which was 2021, 2022, maybe, you taught that modified pelvic injection with an 1.5-inch needle that was so simple. That's a needle that I'm very comfortable with. Your anatomy location was clear. And now I do pelvics, I don't know, 5-10 times a week. because it was just that slight change in how you took this very classic, very, very, very important injection. We as humans hold so much in our pelvis. Just that modification made it so comfortable for me to inject. And so when we teach both, because I think there's something to be said about, if you're comfortable with this tool of doing a Frankenhausen, it's going to give you the same effects. But if you're not, here's an alteration. And so I love the idea of updating our thinking about it to, get the same desired effect, but finding an injection that works for the provider. So thank you.
Yes, I can recognize your way, because it's more or less the way I did. I think it's an evolution. I also was taught with long needles, and as I have seen during these years, when when you introduce palpation in neurotherapy, and when you have more information about palpation for example, on the pelvic and abdominal and thoracic walls, you can use more the cutivisceral effect, the cutivisceral reflex. So the more you palpate, the shorter needle you will need, because you will work through the fascial system. Not all, even the current literature in neurotherapy, they don't talk about the fascial system. So they don't palpate the fascia. They don't treat through the fascia. Sorry, it's impossible not to treat through the fascia. Always you apply an injection, you are also working with the fascia, because it's there. But if you, for example, do the history of life, and after that you decide, because there are a lot of, digestive problems and a lot of symptoms, that you decide to inject in the celiacum ganglion, for example, or in the pelvic plexus. So you decide that before palpating, only because of the history of life. And after that, so you decide to apply the technique. So you have to know the technique, the anatomy, the references. So this is the point to introduce a needle. You need a 10 or 12 or 8 centimeters needle. So you have to introduce from this point in this direction and introduce this amount of procaine. But sometimes, after doing the history of life of a patient, I decide something. So I have some possibilities of injection. But when I ask my patient to lay on their back in my table, on my table, and I started the palpation, sometimes I change that, because I'm palpating that, so I will inject here. And sometimes you inject there, for example, in a superficial injection, and something happen. For example, pain changes, or there are some reactions. So you have to adapt your treatment at the moment according to the reactions of the patient. And I always start with superficial palpation and superficial injections. So most of the times, in my case, there's no need to inject deep injections, to apply deep injections. But of course, sometimes I do that, but not as common as, for example, 20 or 30 years ago. Of course, there are some injections that are ganglion injections that in my case are very common. For example, sphenopalatine injection and stellate injection, they're very common for me. Also pelvic plexus. Also pelvic plexus is very common. Pelvic plexus, also called Frankenhäuser, but Frankenhäuser is not exactly the same. Frankenhäuser are a ganglia, one of the ganglias of the pelvic plexus. So the pelvic plexus is the whole vegetative plexus of the pelvic area, and they include the Frankenhäuser ganglion. And we have changed this technique also, because when I started neurotherapy, we use a longer needle, and we have to introduce in a perpendicular way. And after 4 centimeters, we have to reorientate the needle to the anus direction. So at the end, they were more or less 10, between 8 or 12 centimeters. But only if you push with your hand the abdomen of the patient, you reduce 4 centimeters, the length of the needle. Only with that. With 4, 6, or even 8 centimeters, it's enough. So you need a shorter needle to do the same injection. And also it's safer, because you are fixing the tissues, and it's safer. And you don't have to reorientate the needle when you are 4 centimeters deep. So that's it. But for example, I wanted to learn well and to study this technique with cadaveric bodies. So I applied this technique in cadaveric bodies with latex, with colored latex, and in order to, after the dissection, to know exactly where the latex is going, and using this. In these dissections, or sometimes magnetic resonance, you can know more what you are doing and change the techniques in order to do that easier and shorter. For example, Franco Donati from Italy, he is doing this technique, this pelvic plexus, with a 4 centimeters needle and introducing only in a perpendicular way from the same point. He's starting the same point, but introducing 4 centimeters perpendicular. So this is before the peritoneum. So you release the procaine in preperitoneal, but after that, Dr. Donati asked the patient to change the position in order to put the body in a frontal position, like the thinking man. And with this changing the position of the pen, he has realized that the procaine can move. And he has shown with magnetic resonance. He is doing a magnetic resonance after 10 minutes or 20 minutes after the injection, and he can see how the procaine have reached the pelvic plexus without injecting there, only because of changing the position of the patient.
Yeah, that's interesting. I had a patient the other day that we did the first cervical ganglion, and then I was going to do something on his back, and so I had him, turn on his tummy, and he's like, "Oh, well, my mouth is all numb, like here." I was like, "Oh, okay, wait, turn back." But that's really neat. I thought, oh no, I did the wrong thing. But it's neat to hear that, because just to consider utilizing that even to help the procaine spread sounds kind of cool.
Sorry, can you repeat, please?
Yeah, no, it just to think about utilizing that as a technique to be able
Yes.
to help the procaine spread is,
Yes, yeah.
I
Sorry.
just think
Yes,
that's really neat. Yeah.
yes. Because when we study in cadaveric bodies, the procaine doesn't spread.
Right. Yeah. Yeah.
But even we can see how the latex, but latex is not fluid, it has a high density. But even with latex in a dead body, you can see how the latex is reaching different structures. It's not fixed there. So you can imagine in a body who's alive and with a very fluid substance like procaine, yeah, it is spread a lot. Of course, is if the procaine is injected inside the muscle, it's an intramuscular injection, the procaine will not spread a lot because you will inject into the muscle. But if you inject the procaine in the fascia or between muscles, for example, or in a cavity, or in a structure with a lot of connective tissue, the procaine will spread a lot.
David, so every country is different. What's the state of neural therapy in Spain and Barcelona in particular? Like how is it? Is it part of the medical system? Is it completely different?
Well, it's not recognized, so sometimes it's better. For example, you know that we are doing a master's degree in the university, but it's recognized by the university, but not by the government or by the medical chamber, the medical institutions. So you can work with neurotherapy because they don't recognize it. So I'm a medical doctor who is doing medicine and using local anesthetic to treat my patients, only that. But not as a neurotherapy because they don't accept that. So it doesn't exist for them. But in other countries, like for example Colombia, neurotherapy is regulated by the government. It's recognized by the government. But in Colombia, for example, all the traditional medicines are recognized, or a lot of traditional medicines, because they are recognized as a medical treatments also from his country, from his history also. So recognize different traditional medicines and also alternative medicines. And they include in this box, they include a lot of therapies. I think that it's good in one way, but it's not good in another way, because they will regulate that. So people who don't know what's neurotherapy will say how you have to apply that. And they will establish a lot of rules and you will have to follow them. and who established these rules? Somebody who doesn't know who is neurotherapy. So the rules in Colombia, for example, are very, very hard. And your office has to be prepared as a small quirófano. Do you say quirófano? Yeah, where you the surgery, where the room you do the surgery. in a
Yeah, like a room for anesthesia and surgery. Yeah.
yes, yeah, yeah, more or less. Yes, a lot of very very hard conditions to apply neurotherapy because you are injecting ganglia and you're injecting, so it's a very, you have to follow a lot of very very hard rules. But that's one of the reasons, because I think we have to change our terminology. In our book, for example, in our book, I have changed a lot of terminologies. I don't want to say, for example, ciliary ganglia, because we don't inject ciliary ganglia. For example, an ophthalmologist, a friend of mine, wanted to do a study in her hospital. She's working in a hospital. She's a neurotherapist, and she wanted to conduct a study. And she said that she wanted to study, I think, the glaucoma, injecting the ciliary ganglion. But in the department, the chief of the department said, if you want to inject the ciliary ganglion, you have to use a lot of technology, and it's dangerous, and perhaps it's difficult to pass a scientific and ethic committee. But in fact, she doesn't inject ciliary ganglion. But in neurotherapy, we say ciliary ganglion injection. But we are not injecting there. We are injecting in the orbitarian cavity, in the orbitarian fossa. But we don't reach the ganglia. We inject in the posterior part of the orbitary fossa. So why we say ciliary ganglia if we don't inject ciliary ganglia? We will have some confusions and also some problems in that cases like that if we want to conduct a study. But if we say, for example, I want to conduct a study about glaucoma injecting the fossa orbitaria, there's no problem, because injecting fossa orbitaria, the posterior part of the fossa orbitaria, it's not difficult. And you don't need high level technology to inject there. You only have to introduce the needle into the posterior fossa. But we know, and we can explain in that study, that the injection of local anesthetic in the posterior part of the fossa orbitaria the local anesthetic will reach and will affect the ciliary ganglion. But the terminology must be different. It's the same like other, for example, a celiac plexus. We are not injecting, in fact, the celiac plexus. The celiac plexus is very difficult, and you need also a radiodiagnostic equipment. We are injecting in the retroperitoneal fossa. It's different. But the injection in the retroperitoneal fossa will also have an effect in the celiacum plexus. But the injection is not there. So we have to change this terminology. And I think it will be less common to confuse neurotherapy with anesthesiology treatments. So we have to change this terminology.
Yeah, that makes so much sense. I'm so
And it would
glad that you're
change
doing that.
everything. Like
Yeah.
it would change. I mean, honestly, it's so simple what you're saying. I don't know if I've ever understood it. Like I know when we teach the stellate, we're not doing an intra-articular injection. We're not going within the stellate space or within the ganglion. But I don't know if I've ever thought to explain it so clearly. It changes everything. Words change
Yes,
everything.
yes, and if we want to be recognized, it was because about your question. If you want to be recognized about from your government, first you have to think if it's a good idea. Yes, of course it's a good idea, but I think but also we have some secondary effects. According to the stellate ganglion, of course, we cannot say a stellate ganglion injection. Because we are not injecting there. We are injecting one vertebra upper, and we are injecting in front of the lateral processus of C6. So it's one vertebra up. So it's much safer, and you don't have the contraindications and the possible collateral effects or complications that stellate ganglion injection has. So we have to be very clear with that and not to use this terminology, because I think we have all these confusions.
Right. All right. Well, one of the questions that we do like to ask a lot of the people that we've been interviewing um is there one injection that you find that you rely on really heavily in your practice that you really like to do?
That I like to do. There are some injections I like to do, and other injections I don't like to do. There are some injections that I apply in nearly all the patients. Nearly all the patients. And at the end, sometimes you start after doing the history of life. I decide, okay, I will go there and there and there. But after that, I start to palpate, and most of the patients are with sympathectomy. We are with a high level of sympathetic tone. So when you put your hands and you see that a lot of fascial tension, first, you start to release this tension. So where I like to start from the diaphragm zone, the diaphragm area, because a lot of tension here in the diaphragm area, and also the chest, the presternal area. So this area from the chest, the xiphoid apophysis, and the diaphragm area, most of the people has this area very tight. So if the patient comes with anxiety, with insomnia, with digestive problems or symptoms, with low back pain or dorsal pain or cervical pain, or any respiratory or cardiac problems, or it doesn't matter, most of the people will have this area very tight. So first I start with releasing this tension. And after that, most of the patients start to breathe deeply. They start to doing high, and sometimes to cry, to do also emotional release. And the guts started to move. So they are going from the sympathetic to the parasympathetic. And after that, I also palpate the temporal area, because most of the people with sympathetic tone, with high sympathetic tone, have with a lot of tension in our. If you palpate the cranial fascia, you have to move that easily. And some patients have that they are very very hard, and they are like bone, and it's not bone, it must be a soft tissue. So I started to inject here only only subcutaneous. You inject them, the cranial fascia relax, and also the suboccipital tension points, because you know that the trigeminal nerve connect with the cervical spine nerves, the first, second, and third cervical spine nerves. They are connected to with the trigeminal, and also all the lumbar fascia also start here in the suboccipital area. So you have the connection from the head, from the trigeminal area, from the upper limb, and also from the thorax and all the lumbar fascia. So everything connect here. So most of the people has these points very 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 tight, but it's not painful. Most of the people don't feel any pain here. But if you touch there, you will find there are tender points, but also they are very, very tight and very strong points. When you inject all these very simple and easy points, most of the people relax, and feel very relaxed. And after that, sometimes I think inside of me, I say, well, what was the complaint of this patient? I forgot that. So sometimes you forgot why this patient was complaining, what was complaining, because you started to release and the patient feels better, and you don't remember what was the reason you started to treat. And sometimes I only do that. And of course you have to consider scars and some possibilities of interference field, like any infections during your childhood, or the chronic or recurrent infections. You have to consider that, of course. If there is an interference field, of course you will inject there. But I like to do fascial release very much. I love that, because most of the people feel very happy and relaxed after that. So if you feel people happier, you feel the wall happier. And if a patient is more relaxed, the wall is also more relaxed, and I like it very much. And I don't like celiacum plexus. I don't like this injection.
So wait, David, before we move on to that, when you're injecting the diaphragm up, you're just very subcutaneous little quaddles or blebs wherever you palpate tension. Is that how you're doing that?
Well, I don't do quaddles. I don't do quaddles. I'm a neurotherapist, and I don't do quaddles, because quaddles are effective, of course, are very effective quaddles, but they are more painful. And you inject in the epidermis. They are intraepidermic injections, and I prefer to inject 1 or 2 millimeters deeper. So you inject in the dermis, but not in the intraepidermis, not in the epidermis, in the dermis, between the dermis and the superficial fascia. So when you inject there, you are bathing the dermis and the superficial fascia. So I stand one hand over the patient, over the area I'm injecting, and I'm injecting with the other hand that is holding the syringe. And as I'm introducing the procaine with this hand, I'm feeling the tissue. And most of the times you can feel how the tissue relax. And as you feel that, you can still continue introducing procaine or stop it, but you can feel that. And you can feel that, but without doing a quaddle. So it's very superficial. And sometimes, depending on you feel with your hand, you can inject and decide in that moment to inject more deeply. So sometimes you introduce half centimeter, 1 centimeter, 2, 3, 4 centimeters, according to the palpation, because sometimes you can feel that there's a tight point in the deepness. Yes, it's more deeper. It's deeper. This point, not superficial. The depth of the injection will be according the palpation, also the palpation, and also the anatomical structures. Of course, if you want to inject some specific structures, it depends on the anatomy. But most of the injections I apply depends on the palpation, but not quarrels.
No quaddles for you.
No, only in few cases. Only few cases, because quaddles are very effective. But only in few cases, I want to apply a very strong stimuli in the epidermis. Sometimes.
Shingles. Would shingles be one of those cases if somebody has a shingles rash?
Sorry, that.
Shingles, herpes zoster.
Mhm.
Would that be an example of when you would do intradermal?
An example. Sorry, an example. Well, for example, not in the first visit, but sometimes I have injected some patients and it's not going very well, and so I have not inject a quaddle. So I decide to also do a quaddle, a big quaddle in this area, and after that, a deeper injection, for example. But I reserve quaddles when I don't see any effect or enough effect in the previous sessions. In some points, but most of them are painful points, but not, for example, for all injections, but for painful points or deeper points. And I want to do a stronger stimuli in the cutaneal reflex.
All right.
It's not common.
Well, David, I know that you have got some family stuff to do today. So
Yes.
we should not keep you any longer.
We are so grateful for the work that you do. Before I ever went to learn with you, every neurotherapy conference I would attend, your name would get spoken as the person who gives other physicians the most confidence to inject. You know, a friend of mine, Wesley Reese, you met Wesley? She's a DO in Long Island with my dad. And she took all of the trainings, you know, when we brought in everybody from Germany and Switzerland. And it wasn't until she went to when you first lectured in Florida, she tells this story about before learning from you, she was like timid and afraid. And as soon as she learned from you that weekend, it changed everything. And she was like, I was like a cowboy with like my syringes and needles. Like I was ready to spin and inject everywhere. If anybody ever gets the opportunity to study with you, there is a way that you transmit information that like changes the energetics. I think what you do is you make this very pokey injection cranial, like energetic in its nature. And I think both of us are so great. We mention you every single time we teach because that's how much you've impacted how we view neurotherapy. Thank you. We are so fortunate to have gotten. I think you are our Puyan. Puyan? Puyan, you are our Puyan.
Thank you very much. Thank you very much, Ilana and Anne. Thank you very much for this opportunity to share this hour. It has been really a short hour, very short hour. We can next time we can do that for more time. And yes, I have heard what you said other times before, because, for example, I went a few months ago to Belgium to teach, to conduct a course there, and also there are some doctors that learn neurotherapy 20 or 30 years ago in Germany courses, and they were afraid of some injections. And they said, no, in this way, with this approach, I have more confidence. And I'm more motivated to apply and to do neurotherapy because I feel safer. So, yes, I think this is a good way to follow with neurotherapy. So thank you very much for your words.
David, one more. Where can people find you? What's the best resource for people to find you?
Where people can find me? Yes, in internet. If you text David Vinyes, you will find me easily. I have, for example, a site which is called terapianeural.com. Terapianeural.com. I created this site in the year 2000, so 25 years ago. And there are another site, institutdeterapianeural.com. I can text you or there. But also I have a YouTube channel with a lot of videos. There's David.Vinyes. This is my channel in YouTube, and also Instagram. So all this social media, David.Vinyes. And through these channels, they can text me. My email, if somebody wants, is David Terapia Neural. I don't know how you say arroba. Rack.
David at therapianeural.com.
Okay, gmail.com. Okay, thank you.
Thank you. Thanks for joining us today. If you like the episode, please like and subscribe to our channel and review us on your podcast players. Also, if you think this episode is helpful to some of your friends or colleagues, please share it widely. If you are curious about learning about neural therapy or other injection techniques, check out our courses on learnneuraltherapy.com. We'll see you next month for our next installment of the Point of Medicine podcast.